So we're called to a 40-year-old male by the name of Tony, who has fallen approximately 6 meters off his roof. He's landed on his occiput, causing a 6 centimeter boggy patch. On arrival, Tony was supine. He was restless, combative, extending his limbs to pain. He has irregular rests with grunting sounds. Tony's vitals were, his blood pressure was 160/110. He had a irregular rest rate of 12, heart rate of 50. His BGL was 7.6, temperature 37 degrees. His SpO2 is sitting at 88%, and we've given him a GCS of 6, made up of 2, 2, and 2. So St. John's treatment is we would put him on oxygen on a non-rebreather mask due to the fact that his oxygen level is sitting at 88%. I would gain a IV access on his ACF with a large bore in order to give fluids. However, you're only giving fluids to keep a systolic blood pressure of 120. Because his blood pressure is already sitting at 160, I don't want to increase intracranial pressure, and he seems to be stable. So the only reason we would give O2 is if his blood pressure, his systolic blood pressure was under 120, or I needed to keep a permissive hypertension. I've called for R50 because he has severe TBI. And will need RSI. The reason why I'm saying he has a TBI is because he's extending his limbs to pain. He's unable to obey commands at all, and he is clearly showing signs of a severe TBI. So the backup is 10 minutes away. I'm going to get my RSI paperwork ready and get all my stuff ready so that when the R50 arrives, everything is ready. As previously stated, I've called R50 for RSI backup. They're 5 minutes out, so I've got my St. John procedures on the preparation for RSI checklist. My partner and I are going to get the gear ready so that when the R50 arrives, everything is ready. So Q1, according to the St. John checklist, we need to attach nasal prongs without oxygen. The reason we'll be attaching nasal prongs without oxygen is because while the R50 is doing the RSI, the nasal prongs will be connected to oxygen so that he is still being oxygenated while the procedure is being done. The second point says that we need to pre-oxygenate using the reservoir mask. As he was saturating low to begin with, he was already on the reservoir mask, so we'll just keep that on and at the flow of 10 liters per minute. It also tells us, Q1, that we need to attach the ECG. We've got that attached already. Yep. We need to attach the NIBP, it's attached, as well as the SpO2. All of those are already pre-attached. We're going to prepare the capnography, if we have one, if you don't mind. The capnography will tell us what his CO2 would be when we are ventilating him. So once you've done that, we need to position the monitor so that it can be seen, leaving a space to the right of the patient's head for intubation equipment. It also states here, Kieran, that I have to gain IV access, preferably on 2 sites. Now, because I've already gained one, I'm now going to gain a second one, and the reason for that is in case we need to flush large boluses of fluids, we've got 2 accesses. So while Kieran is getting everything else ready, I'm going to do the IV. Could you prepare a running line for the sodium chloride? Please do not give it as he doesn't need it at the moment. We don't want to increase his intracranial pressure. In that meantime, I'm going to do the second IV.
Short check, sodium flora, March 20.
Yep, checked. Just going to get my gear ready. So we've already positioned the patient with the optimal airway, which is the sniffing position. We've put a towel under his head to keep the position. We've also placed protection around his head to keep his head stable, as we have not been able to put a collar on him due to it increasing the pressure on the boggy bit. Thanks, Ken. So could you also place an ETT holder under the patient's head, but just not fasten it?
Yeah.
Sharps out. Can you give me a sharps container as well, please? Sharp scratch. Thanks. Sharps and container. Right, so I have flashback and it's flashing well. Alright, cool. Kieran, could you please, according to this, you need to prepare a manual ventilation bag with PEEP valve attached. If you can just get that ready for me and put it on the side, that'll be great.
What would you like PEEP set to?
5, please. Cool. Okay. Could you also do me another favor and get me another set of vitals? And while Kieran is doing that, I'm going to recheck the list to make sure that I have covered everything that's needed, and make sure that the area is clean and tidy, and that everything that's not needed and is out of the way. In doing that, it gives the R50 the access that he needs, and all the unnecessary gear has been removed. Awesome. Thank you, Kieran. Appreciate it. Right, like I said before, we have now covered the checklist in checking that everything that the R50 needs, making sure that all the gear has been removed that's not necessary. Also taking into account that we have things that might be needed if the RSI doesn't work. So, making sure that we know what a bougie is, what it's used for, knowing that the ICP will ask us to thread the tube over the bougie, which is the blue cord that they use to find the airway. We also need to know that if for some reason the intubation fails, that we need to go and follow the procedures in St. John for the failed intubation. Taking note, obviously, that if all else fails, the last attempt for an airway would be a cricotomy. And as I said, we're going to go over the list again to make sure that we haven't missed anything. Right, Kieran. So, attach nasal prongs without oxygen.
Done.
Checked. Oxygenate using reservoir mask at 10 litres.
Done.
We've attached the ECG, NIBP and the SpO2.
Correct. And then a whole set of vitals again.
Thank you very much. We've prepared the capnography.
Just waiting.
Okay. We've positioned the monitor so that it can be seen, leaving space to the right side of the patient's head for intubation equipment. We've gained IV access preferably on 2 sites. We have done that on both ACFs. Prepare running line of sodium chloride.
It's over there.
Position the patient for optimal airway control. We've placed an ETT holder with a strap undone under the patient's head.
Yep.
We've ensured the suction is working and it's turned on. Can we lay that under the patient's shoulder, please?
Yep.
Thank you. We've prepared a manual ventilation bag with PEEP valve attached.
Yep, at 5.
Thank you. We've obtained a set of vitals, as you've said. We need to update the responding ICP with the patient's condition and vital signs, so if you don't mind doing that for me quickly.
Yep, I can do
And
that.
then we've prepared the area, everything's clean, and the patient airway, everything is clean. Everything's moved out of the way that's not necessary. So we're fine.
Done? Perfect.